Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator. This is session number 205. I am delighted to introduce eminent guest who is joining us in the cath lab, joining Dr. Sharma and Dr. Kinney. He's Dr. Roberto Botello. I have known Dr. Botello now for the last about 20 years. To me, he represents the person who knows the best about telemedicine applications in medicine, and he taught me everything about telemedicine. Dr. Botello is the president of the Jateni Foundation, named after Dr. Ateb Jateni, whom I had the pleasure of meeting him in 2012. The Jateni Foundation oversees the Dante Passanese Hospital, which is an institution which we know that brought the Johnson & Johnson coronary stent to the interventional cardiology world. We'll talk more to Dr. Botello. Roberto, welcome to you. Samin and Anu, good morning. We have a truly complex calcified lesions, and I'm sure Dr. Kinney or you will start by introducing to us your new fellows.
All right. Good morning to all our CCC live viewers, and which has been increasing, and the demographics are changing, which will show that. But continue the same mission. Select a case and try to make the points on the complex case. How can we make it simpler? With that note, Anu, of course, we welcome Dr. Roberto Botello in our cath lab, and he has been part of our CCC symposium, complex coronary symposium, many times, and of course some Indian meeting. And welcome, Roberto, and we'll take your input in a very complex case. Anu?
Yeah, no, I'm introducing our two new fellows. July 1st we start. We have Franz Berkins.
Yeah.
And he's actually from a Mount Sinai Cardiology Fellowship, originally from Amsterdam, completed his PhD there, and now stayed here to learn from us, and he plans to go back. And then we have Gregory Ophia, who is right there. He is actually from Ireland. Yeah. So we have like a multicultural from multi-country, everybody come to learn here, and both of them are interventional fellows, and already first few weeks are done. They are ready to do all the complex cases with us for the next few months.
And rest of the staff is the same. Asif and Naira, the CVT, and from nurses, Mark and Will, and Kiski on the OC, on our imaging, and so. So with that note, if okay, we start our case, our CCC live cases, our target audience, the overview and the learning objectives remain the same, and we are thankful to Broadband AV doing all our live relays. This is no change in the financial disclosure. And then, of course, we added our guest moderator today, Roberto. So now these are our commercial supports by the font size. It tells us that how much they support, but everybody wants to be the part of our ever-growing CCC live. So this is basically that now things have gone. It started with the coronary 2009, 2012 peripheral, structural 2015. Now we added the imaging and microvascular. So all types. So every week there is some educational teaching from on this banner of the CCC live webcast and live webcast. And this is actually very interesting. Put in the one slide. Overall, over the years, you can see last 2-3 years, around 29,000 hits per month. And more important is the demographic is changing. So if you take the last 2 years of the 2004 to 2025, the United States and India, I put it only first 4, and then last year, basically 25, from January to June of 25, you can see that India has superseded in CCC live, and with the percentage of the 28,000 people. And now, actually, very interestingly, the China has climbed up, and India has beaten, I would say, USA. And we know, Samir, you know it also, by going to India, everyone is so thankful. What we teach on this point without any commercial bias, and really try to teach everybody the technique of the intervention. So with that note, let's go to our today's presentation of the case number 205 with the 81-year-old who presented. Actually, it did good. This is age of 80. Not much, little bit here and there, slight blood pressure issue, but and cholesterol, and and has a AFib, and then he had a very high coronary CTA, I mean calcium score, and had a 3 vessel and left main, and they did CTFFR positive in all the vessels. Risk factors on the left side well controlled, and he's apixaban, torvastatin, and some anxiolytic, no other medicine. So cath actually will show, revealed also 3 vessel left main which came on the CTA. Ejection fraction was normal. Look at the calcium everywhere, which we expect at age of 81. This was a very calcific right coronary artery, which we did with the orbital atherectomy, followed by 2 stents. That's what we did. Beautiful, fantastic results. And now here we are for this left-sided, where there is a disease in the left main, additional disease in the LAD, diagonal, and circumflex. Anu, you want to comment on things?
Yeah, so I mean, you can see the tramp track calcium, left main moderate disease. If you see there, the good thing is 7 French, and we don't see, we can put the hemodynamics, we don't see any kind of ventricularization. So this is in the circumflex, significant disease in the prox LAD, diagonal D2 actually, large size, osteal disease, short, but then after that you see a bridge. So that is why I think any kind of atherectomy we do, we have to be very cautious that you do not enter the bridge. So this is where we are. So I already wired the LAD with a wire. And I think this is the kind of case where we know you have to do atherectomy. We go directly with atherectomy rather than imaging.
Yeah. So let's ask Roberto, you have availability with your orbital and rotational. You have preference to one versus other in this particular case with the diffuse calcification, little bit of angulation and so. What would you use in your lab?
Samin, can I ask another, even a more fundamental question?
Yeah, sure.
Roberto, would this patient in Sao Paulo go for cardiac surgery?
At 81.
Yes, no, definitely not. He would go to the cath lab.
Excellent.
Percutaneous approach, and particularly if you can get a residual syntax, a low residual syntax, it's proven that it's absolutely compared to revascularization. At 81, we would send to the cath lab. But in the hands of Dr. Kini and Dr. Samin Sharma, definitely percutaneous.
So Roberto, move now to Samin's question. How would you tackle it interventionally?
Yeah, or would you just do IVL? I mean, that's another valid option in these kind of cases.
Dr. Samin, question about orbital versus rota, and particularly from the data we have, it depends on the operator experience. They are similar to each other, and from my personal experience, I learned with him. You don't know, but you taught me rotablator. Then, but there are some advantages by doing orbital because it's a tight lesion and you preserve the flow. It's a large vessel. You can treat. We'll see how deep is the calcium. Then it's a good case for orbital, and similar to IVL. IVL may bring lower complication rates, but it's not the case in this cath lab.
Excellent, excellent, Roberto.
Okay, so we are ready with the OA. The question here is, Anu has been a little doubt whether we use OA versus RA, but I think it's okay. Let's try OA. We have taught everybody in our 205 episodes. I'm sure Rota has been done in 120. And so people definitely want to learn a little more of the orbital atherectomy. If there is any question, you put this Viper wire directly. Okay.
Samin, so you had mentioned about, and I've got the majority of the people joining me are at the moment from India, where I think Orbital is being launched or it is taking up shape. So seems a very good idea for our audience as well.
Yeah. No, actually very interesting as you mentioned. I started the orbital both places, both continents, USA as well as in India.
You and have India done many things on 2 continents, I mean.
Yes, actually 3 because Brazil is included.
Thank you. So key is it's still quite a bit of interest despite the Eclipse trial. The numbers have not gone down in India. Actually here in America has gone down significantly. And the case using this is kind of case you can use orbital. I would say you need to be away from orbital in two situations. One, if it is a aorto-ostial disease, and secondly, if it is angulated. It's very tortuous this because what happened is the wire. We have two types of wire, the Viper wire and Viper wire flex. So basically flex goes to this tortuosity. Otherwise, the regular Viper wire, which is 0.012, it cut the vessel in the angulated area based on the wire position, and that's where the concern comes. But majority of them can be exchanged, whether to rota versus orbital atherectomy. So in this particular case, we thought since we did a great results with the orbital in the right side, so we just use it same one. One of the people say that using orbital, then you can go to the large size, you can get a better lumen. Although we rarely use it, but in right coronary, I did go to 120,000 RPM. Not only just 80, but 120. We say 120 should be done in very, very selective cases because that is the speed, cause a little more dissection and a little more perforation that we learned very early in the use of orbital atherectomy.
Is Andrew still there?
Yeah. Good. Okay, so Viper wire was done direct wiring. This kind of case, which could be done directly. Otherwise, in a tortuous case, you'd use a fielder fine cross and with a workhorse wire. And before going in, we always say, now if you can see the top on this, basically this is the brake release. You put a brake and check the speed. And when you check the speed, it should not be touching the towel, knowing that it's working good. And
RAOA,
then let's start going in.
a slide.
That's a very useful tip, to prepare it. Roberto, what is happening for calcification in Brazil and in Latin America? Is IVL the default, or is it too expensive, a combination of rotablator and IVL?
Rotablator is the leading approach, and IVL is too expensive. It's very difficult to implement. The rota is number one.
1 millimeter per second, and then
at Dante Pazzanesi, we're doing like less than 1% of the total case.
Excellent.
So orbital is 1 millimeter per second forward as well as backward, because it will ablate the plaque both ways, and it stops at 25 seconds. It's company made the set alarm at the 25 seconds. So when you go forward, compared to rota, when we do a backward forward, here you can do continuously, and then 1 millimeter per second, and come back also 1 millimeter per second in order just to get better ablation. After you're done, maybe 2 or 3 times you do, because every time it will go into a different area of ablating in the vertical axis in the sphere. So therefore it's a slowly keep going and then keep coming back. No need to stop, and as you continue, so you'll see a 25 seconds will make the noise.
Samin, purely from a conceptual and engineering point of view, a pretty neat device.
I can tell you there is even a better device which is just introduced in India in atherectomy, is a 1 millimeter, and that has both rotational and orbital based on the speed. Otherwise, a 1 millimeter bar, but that has the diamond coated both proximal as well as distal, fully coated, because rota is not fully coated, orbital is not fully coated because tip has no diamond chips, and that has been the what?
I finished.
No, now if it's okay, we can do a 120 in this particular case, large vessel.
No.
You want to take a little picture?
The lesion was significant. I would not
Cine. Just do a cine, you can do cine. 7 French in this 1.25. We'll be able to see. So this is the case where I would be okay as long as you have no perforation. Go to the second speed, which is 120. Just 1 or 2 times and so. Yeah, different noise comes.
Yeah, totally different.
Yeah.
Toyota versus Ferrari.
No, I wanted to make one noise of 25 seconds so the audience can see it makes the noise at 25 seconds. That's a stop, and the same speed forward and backward.
Samin, one of the other advantages is also a single unit,
Yeah,
you don't need to change the size.
that's correct. And the same way with that 1 millimeter bar, which is done by Merrill, and
Merrill
just to put
making this new device makes
yeah,
all the sense, you
yeah,
know, with
yeah,
all the diamonds which come from Surat.
yeah. Okay, good. Yeah.
Samin, also I'd like to introduce and welcome both Franz and Gregory to the program, and I think it is also in order to congratulate you for becoming the chief of cardiology.
Beautiful. Yes, so I would say long, many years of hard work, and it's very important that the
No,
institution
only 41
recognize.
years, only 41 years. Incredible.
Yeah,
So
good.
Samir, you can see, you know, you were talking about physics. You see that how this
Right.
orbital atherectomy works. So you really want the effect
Such a
of orbital
beautiful
atherectomy.
illustration.
Yeah, so
Beautiful,
you really
yeah.
want the orbital atherectomy effect. You ideally should be 360-degree calcium, because if you have 180 or less than that, that is when you have a risk of this. You see that the opposite wall, when there is no
Beautiful.
calcium, it will actually cause deep medial injury.
Once
And I think,
again, Anu, a demonstration of what we speak. You show it to us so beautifully. What a lovely slide. Perfect,
yeah, so
perfect.
that is one. And you see the physics principle. Okay, why you go with the increased speed. So when you go with increased speed, you remember it's divided by the radius. When you go with the increased speed, the mass is the same, but that's when you can use it on a larger vessel. The only benefit that you don't need to change the burr size. So you increase
Right.
the speed, and then it will, the radius will improve. That is how you are able to get into the larger vessel. That's a benefit. But I think very important is the way
Shunay.
orbital atherectomy works, and that the diamonds are both forward and backward.
So Roberto, right here you see what
Beautiful.
Dr. Sharma had mentioned at the beginning of the case, a pure educational perspective. We've shown how to use the device, its scientific benefits, and I will not be surprised. I don't know what Dr. Sharma is going to be talking about, but I bet you there would be also academic aspects of the trials and what has brought the technology forward. Samin and Anu, just outstanding demonstration, and I hope it's very helpful to our audiences globally and particularly in India.
And look at they did a great job.
Second, Andrew, can you also show the similar one that we have for rotational atherectomy?
Excellent.
And Samir, Dr. Sharma also give us tips and tricks, and now they are exchanging the wide. And one question is that the orbital wide is 012, and now he's changing for a 14.
Exactly.
Is there, Dr. Sharma, any case you can go direct with a stent with the same?
Yeah,
the
so
same
very
wide?
good point. We have not done it. Some people have done. Reason is majority of our are, you want to imagine? Okay, majority of our cases are 80,000 RPM, so we always post dilate. And this is a large vessel you always want to see, because now we have IVL. And I always say, even for the rota, your second bar is IVL. Rota, you step bar almost disappeared, and it is the second bar is the IVL. So use the smallest bar, whatever you need, 1.5, 1.25 in some cases. Don't upgrade. More complication, more trouble. After you have made the room, IVL is second. But now, of course, the cost is a big issue. So therefore, you just go with the non-compliant high-pressure balloon, and particularly the open double-layer balloon works very well, although it's still a little more costly. Just to give, regular balloons are $65 in America, and our cutting balloons are about 600, and open NC is about 1100.
Okay, can you
IVL is 4500.
literally
Rota is about
screen?
2000, and orbital about 2600.
Okay, so let's do the imaging, then I'll go back to this rotational atherectomy, how it works. Yeah.
Okay, start
So
pullback. It's a
there's a
Watson
bridge
Arrigo
there.
plus,
You
plus
can see the
pullback.
bridge, right?
Yep.
Yeah.
Now the eccentric calcium.
Keep flushing.
Now prox LED. Now left main.
And see if there are any cuts.
Stop it. Yeah, you can take it out. Yeah, Okay, start of the pullback not much calcium, and vessel sizes like 3 vessel.
No, what are you saying? No calcium?
The start of the pullback is no calcium, but now coming back.
At the level of the
Yeah.
diagonal, yeah.
Yeah, this is a like 180 eccentric
Mhm.
calcium, and some leaf ablation. The surface might be shaped because the leaf ablation multiple reflection. Here's also very obstructive eccentric calcium. Now I see that some blunt. Maybe this is the level of the left LAD bifurcation. Now come to the proximal LAD. Here's also eccentric, like 180 degree of the calcium.
Now,
Okay.
what are those multiple cuts? What's these?
No, they are not.
This-
I don't think that.
So yeah, another point is this is left main bifurcation. Now come proximally. This is a distal left main. This is, of course, this is after the OA, but looks like now not that much tight stenosis.
It's still tight.
No,
Is that
it's not tight. Distal left main is saying is okay.
after OA? Yeah.
Now,
No,
after this now.
No, I won't say after OA. I think it was okay. Remember, we didn't say any ventricularization.
Yep.
Roberto, what? Yeah, Kiski, please complete.
No, just very short
Yeah,
left
maybe
main.
So
and,
no, what I'm trying
no,
to tell
looks
you
not
is
that
most of it
obstructive.
probably was a deep adventitial calcium, right? It's 180. So
mostly
we are
180.
still in a mild to moderate, not severe calcium here.
No,
One
here,
little
no,
bit.
right here.
That's
You have,
okay.
you have
Just a little bit.
270 plus.
Yes.
Yeah,
And
in
looks
this
like
area.
surface
And
is,
there is a cut.
Tiny.
yeah, surface is shaped. Yeah.
No, that's not. It's a surface is shaped. Let's go back. Okay.
But we are early on. We published in our 20 cases of OCT rota versus OA, and we found the deep cuts with the OA. Although
Yeah,
it
we
could
call
be
it as we used to call it
crater.
as crater, but it's more of medial injury. Yeah.
Put a
So
wire
that's
in the
what we
diagonal
see.
also
We'll go
now.
into the diagram. So if we
Roberto,
go back to the rotational atherectomy slide, yeah,
Yes,
Yeah.
go back.
Now show the RA slide, rotational atherectomy.
You are asking him some question.
yeah, I wanted to wait for you to demonstrate that and then go
Okay.
to Roberto. The question was regarding both at Dante as well as in Brazil and Latin America. What is the use of imaging? What is the philosophy? Are you dedicating it only for very complex situations or using it more and more?
Following the recent guidelines and the way image impacts in outcomes, we are using more and more, particularly in the complex case where you, like this one, calcified, and it's very helpful to decide of sizing. Then it's being used in Brazil, but the reimbursement is not allowed in the public area, only in the private. But I believe it's average of 5% of the cases.
LED.
Exactly right. Very.
352.
Anu, you want to talk about that beautiful slide again?
Okay, so this is the differential, how the rotational atherectomy works. You see that how rotational atherectomy works. So differential cutting, and there is deflection of the tissue, which is very, very important mechanism, which the way rotational atherectomy works. So why this is important is that in like this situation, we did not use the imaging beforehand. Okay, in I would say less than 0.5 millimeter or maybe 1 or 2 quadrants, there is severe calcium. The rest of the area is moderate calcium. In situations like that, like I showed you, the way the mechanism of orbital atherectomy, you need to have severe calcium, 3 quadrant, 4 quadrant calcium for it to orbit and do the mechanism the way orbital atherectomy works. But rotational atherectomy is deflection of the inelastic tissue, like we see there, or elastic tissue, and the calcium that is there, which is being, atherectomy takes care of it. So for that particular situation, even if it's mild calcium, moderate calcium does work better. So in the bottom line, probably if you have a situation, probably it is safer to have rotational atherectomy than orbital atherectomy, because with orbital atherectomy, you got to make sure you have severe calcium.
Wonderful.
Okay. So this is a 3.5 20 millimeter non-compliant balloon. Go a few millimeter more. You just need to go
Don't
after
go.
the
So
diagonal.
it's
No, just
yeah,
after. Yeah, just
okay,
a little die.
good.
See it?
Yeah.
That we are not in the bridge.
But I think you have to cover the bridge. Bridge has a lesion, right?
Lesion, yeah, or
pretty
Huh?
lesion.
Bridge
significant.
has a
Yeah.
lesion. Yeah,
Yeah.
Or
has
plaque.
disease.
Then
Is
you have
that a
to
bridge
dilate
plus
with this
disease?
also.
I don't know. I would go with the
Direct.
yeah.
Okay. So now question is the strategy.
Yeah.
Do you want to put a mini crush of the LAD diagonal, or we want to bring it to the left main, because there is a circ lesion also. There is a significant lesion in the circumflex. You want to dilate now?
And the diagonal is a pretty large vessel.
No, diagonal we plan was to do mini crush.
Right, right.
Then question was for the left main, do you a double mini crush versus what?
No, I don't think left main. Go back.
Ostial LAD. Is there a lesion in the ostial LAD? That is the
Yes.
contributing here.
This is
We are-
just after the left main bifurcation. This is the austere LAD.
Oh,
Like
very good,
270
Jim.
calcium.
Exactly. You don't need a
We
wing
are-
crush.
Yeah. That's the ostial LAD. Oh, good, very good lumen.
Yeah. And
Well-
distal left main is also okay.
If we
Yeah.
can show the imaging again, please.
Okay. Yeah.
Yeah. Show the imaging, please.
Yeah, perfect, excellent.
You see the austere LAD area. There's some-
7.4.
Yeah.
That's a post. You can call it a post.
Yeah, sure.
Yes.
Yeah. Okay. And tell us what's your strategy now. What do you want to do?
Let's cut the dag, mini
Okay,
crush up to
2.5.
the
Yeah.
ostium, then take care of the circ and end of the case.
Okay. Get a 2.5 cutting balloon.
Samir, did I make it clear about the
Very
physics
nicely
and
clear.
how
Excellent,
OA
excellent.
and RA works? Yeah.
Wonderful.
The
Great
principles.
illustrations, beautiful slides, plus your explanation is top on. Roberto, a moment, take us and describe to us. I'd like people to benefit from. Brazil has always represented to me some of the finest interventional cardiology, some innovations. I've personally known and read a lot about Dr. Jateni. Just to tell our audience, he performed the first arterial switch for the transposition of the great arteries, and the Jateni Foundation oversees Dante Passanese, which is the greatest interventional cardiology institution, and you serve on their board. You were telling me that they had something like 300 fellows and a few thousand. Tell us some details.
Yes, Samir, there is a large educational program from Dante Passanese in the hospital, and we also broadcast a lot of programs from different areas.
Go a few millimeters.
And yes, currently there
So
are
this is the
300 fellows in the hospital,
ostium,
and
maybe
it's
get the
a
ostium,
400 beds hospital and 10 cath labs.
Oh,
And the way we train people and we educate them it's very similar to what Dr. Sharma and Kini is doing here, because we receive a lot of very complex cases, and we run some post-graduation program.
careful.
Look,
Don't
and
go high
also
pressure. Mega.
we accelerate some startups to teach them how to get into this field
6.
of innovation.
Excellent.
So we can
Okay.
take a 3.0 or 3.25 48, cover the mid lesion.
I don't think you need 48. 38 should be okay. And the 275 to the diag.
Two,
Oh,
yeah.
Roberto,
Dissection, that's okay.
we've also had good friends at Dante with Fausto Ferris and Ricardo Costa, and exceptional
12 or
exceptional
15.
work they do.
3.0.
Yeah,
right?
3.0. 3.0.
Samir
LAD is
Fausto
3.0.
is
275 to
connected
the diag.
with us right now.
15.
He's watching this case, and
Wonderful.
send the best regards to everybody here. And
Synergy.
he wants to collaborate with Mount Sinai with
Hey,
some
no,
international programs.
Zions,
Fantastic.
right? He is,
What we did last RCA.
Welcome,
Synergy, then
Fausto.
synergy. Go synergy.
We've collaborated very closely with many initiatives before, including MedStream 360.
Can
Yes.
we do Zions?
Yeah,
No,
MedStream
synergy.
was amazing.
I wanted
Go
18 to the diag.
2 years ago,
16,
Dr.
16.
Sharma
Okay,
did a
16.
live case to the
16.
National Society.
2.75 16.
He treated
3.0.
the calcified
38.
left main with laser, IVL, and rota, and also cutting balloon in the same case. He did it in 25 minutes and created a huge problem at the interventional community.
He made all of you look so slow.
Yeah,
more than 38 minutes.
25 minutes.
Okay,
Yeah, so
48.
no,
30
but
or
that
48.
was this is, I would say, one of the case where we are just ready to kind of give up. We used all the material. We made that educational case in box.
Yeah.
Superb.
Done?
Everything, step by step, we went into and finally able to do it. And what happened is, Laser gave us a little room.
Oh,
Laser didn't cross the ostial LED, but
Yes.
just gave us the room, and then we are able to put a rota wire, and rota wire did the job.
Yes.
So Laser didn't go, but made enough room, because before that, no catheter went to the ostia of the LED. So once because little room, we put a fine cross again, and then put a rota wire, then 1.25 bar, and case for the history.
we have to make sure it doesn't come up to the ostium.
Huh?
Because you have to do the circ.
Roberto,
Yeah.
we also would like to, as CCC live cases has been expanding globally, another area we want to expand is to Latin America and to Brazil, and we'll probably use your help as well as the help of Solasi.
Definitely, Ricardo Costa is the current president of Solasi, and he's at Dante Pazanese as well. And I wonder if we could start this program by having you in the Cath Lab in Brazil to launch a live CCC through Latin America. We run
Excellent.
regular programs across Brazil, and we do a lot of transmission as well.
You need to inspire either Dr. Kinney or Dr. Sharma to take them there and have them extend their educational abilities to the entire continent. They've transformed interventional cardiology in so many countries. As Dr. Sharma mentioned, the reach of CCC Live, and it's actually not surprising, because India and China, I think, will easily surpass the United States in every aspect, both interventional cardiology and structural heart.
Yeah, and actually the Avizad we brought the team to start affiliation, both academic and clinical. Talk with Roxana Meran. So that part is still in kind of we are working out.
See, I did tell you, 48
It will be
will
our
too long.
great pleasure, and let's trigger. Actually, Dante Pazanese is connected. They are live and following our discussion. So Fausto is now pushed to start the
No, it's
program.
coming up to the
Alex
left
Excellent.
Webside
That's okay.
is
Cover the
our
whole thing.
brother.
We'll make a hole, and
We
then
did
we'll
our
serve.
fellowship together
Yeah.
at Dante Pazanese.
Hold on.
Yes,
This
looks
is
very good.
So we do a lot of collaborative work with him. He's at INCOR. It's a wonderful institution in
Great
São
hospital.
Paulo as well. We can connect both of them.
I want to put to 38.
Put diagonal further. So now what happened is we selected the long stent. This is the Synergy 3048.
Mm.
Yeah, that's okay. It's going good. See the slowly, without pushing the guide. So no dissection. Slow movement.
Okay.
And I think it's done the job.
Show me some dye. Okay.
Yeah.
Mm.
Will be very good. Okay. Good. All right.
I don't know. I was taking 38. Mm. Yeah, see, we'll have a problem. In
Remember, it's a
putting-
Synergy, the dot there.
It doesn't matter.
Okay. I think just, but we have to go to other view.
Mm.
See it
Okay,
again. You want to take a picture?
Yeah.
Remember, dot is further. The stent is inside the dot. Go back to epicranial. Good.
Okay.
Samin, I'd like to share a lovely story with our audience.
Go on.
In
Not
19...
yet. Some dye. Some dye. Yes. Okay. Some dye.
My first...
Mm.
Good.
Okay, good.
Ready?
Is this the diag?
Diag. We are going to the diag now, which is 2.75,
Yeah.
16, 14 atmosphere.
I mean, as you treat this diagonal, a quick story for our
Yeah,
audience
go.
and some of the amazing lessons you learn. My first visit to Sao Paulo was in 1993. I had gone to teach laser, and the person I was teaching was the director at INCOR, Dr. Shigematsu Arie. And the day I went to teach him the laser, he had 137 cases scheduled, and they used to work 24 hours a day.
Yeah.
That is the power and which Dr. Botello just mentioned, which is where Dr. Abizayed is at the moment. Brazil and its institution of interventional cardiology dates back almost as long as ours.
Absolutely. Superb. So that's the area of the bridge. So we are just going 10 atmosphere there. There's a calcium at that bridge. Usually there's no calcium. They're soft, but there could be a lesion, but there is a calcium is not expanding, low pressure, about 13, 14. And we have to post dilate anyway. One second.
The mid portion.
Yeah, no, that area. Yeah, exactly. But we'll post dilate. Yeah.
High pressure, yeah.
Yeah, exactly. Because rather than with the balloon or the stent balloon, it may cause more injury at the edge and dissection. So now we can bring any balloon in the middle, which we have 3.0, get the 3.0. No, we have 3.5 actually. Yeah, that's okay. We can 3.5 because vessel was 3.5.
Sharma, do you feel a lack of a mismatch between the IVUS and the angio? Because I expected more calcium, as we now realize that.
Right. There's a big discrepancy here. I would have said everything like a full circle. But
it could be adventitial calcium what you're seeing. Deep adventitial calcium looks that way, but.
And you can only see that by the OCTs where it is.
Yes.
Otherwise.
No.
Yeah.
I learned with you 10 years ago that when you have calcium both sides of the angiogram, you don't need image to decide for preparing.
Fantastic.
Okay. Ready?
Looking good.
That's the area. Except that the area, I think we should get a 3.0 in that area. We have to cross the diagonal. Let's recross it. And I would say just with the 3.0, why don't we dilate the ostium of the diagonal, take it out, and we open that area of the LED.
Samin, right time for you to start your...
Tell us, AK, what the plan is.
No, I am not happy the way the LED looks at the level of the diag.
No, I know. That was the calcium. And we did go with the orbital until there. But now may not have to cross completely. So here is the safety point of view. I think it's reasonable to just go with a short balloon at that level, 308. And if it does not do job, then may put IVL. IVL will be safer.
Anu, what were your thoughts about that?
That how to take
No. Look at it. I think what has happened is the thin strut synergy stent. You see that? Probably has recoiled a lot. Can you see at that level it is?
I was a little concerned when we saw that. I think it'll be fixed by post expansion, but
at the level below the diag, what did you see on imaging? Was it eccentric?
Eccentric calcium after the D2. And the other half is plaque free. It's
you want 308, I think. No,
here we have to go 212 balloon first.
Okay.
You want a 308?
Yeah.
Or 12?
12. Go, okay. 312.
312 high pressure, so we can finish the kiss.
And the
212. You want to leave the circle on? Because we have so many lectures to finish.
No, we'll continue to do the circle. He's not coming back third time. There's a very tight circle, Ian. We'll try to work through it. Let's see.
And again, it's calcified. It's a lot of things. No, nothing is
easy.
Yeah. Please.
Oh, no, that is also calcified.
Yeah.
Very
so
calcified. We have to use IVL. If not rota, the IVL.
That's what I'm saying. Maybe sometimes they have to come 3 times.
Yeah, that's okay too. We can bring back for the circ 3 times. That's no problem.
Yeah. You want to start your lecture so that we
Yeah,
can
yeah.
finish
No, but
this
that's
balloon and be
let them
done.
know. People sure want to see that lesion expansion. Ready? Okay. We are going with the 3012. That is that area of eccentric calcium. Right now I'm at 18 atmosphere.
Can you go back to the IVUS and show me distal to that
Samin,
sure.
I
diagonal?
thought you would take a 3-5.
This is the level of the diameter.
No, vessel is 3-0.
Yes.
I mean,
Okay.
There,
Eccentric
no,
calcium.
3-5 is the standard region. Is you 3-5, you go 22 atmosphere. Then you're more trouble. And the fellows always ask, I go quarter size lower, so we can go much higher pressure. And I said, that's okay.
3-5 at 22 is approaching almost
Yeah.
4.
That's right. Yeah. Okay. Okay. This is the area.
Yeah.
Okay. Let's see how much we want to go. 20.
is that what it is at the level of the
Yes,
diag?
this is distal to the D2.
Huh?
Exactly. This is a place.
Doesn't look bad. What are you seeing at 6 o'clock?
Leave it there and here. Go
The
forward.
edge of the calcium and some other plaque, but it might be some
Hematoma.
maybe because of the acoustic shadow of the calcium, we don't see behind the calcium, but there might be. And Angel also has some like a possible one, right? Before stent.
So we're going with the 2012 to the diag.
Yeah. First, because of those calcium. And so it's not left main. Left main you can still go when you're doing a mini crash, that you can go with a big balloon. But otherwise these you have to go with a small balloon first, because that itself will give a little trouble. And here we can maybe anchor it, put a LED a little further. We have a long room. Yeah, good. 4 atmosphere or 6. Good. And now we go.
Andrew, show the anchor.
That was the bridging area.
Yeah, that's the bridge.
We'll recross again. Or
Okay,
otherwise 1.512.
Okay, good.
Okay.
Ay, ay. Okay.
Good.
These are the live case tipping point, and a lot of tips and tricks that helps interventional cardiologists across the world. I wouldn't have used these. I just learned.
Go up.
Yeah.
So
It's amazing
Roberto, intriguing question for you. I'm glad I got
You have to go high pressure, right?
Yeah, 20.
a visitor to
No,
our
no,
cath lab to ask.
275
Who do
high
you
pressure.
think is
That is a
these?
275 high pressure.
Who do you think are these cases better for? The fellows or even
Go up
people
there.
in practice?
I think both of them. The fellows learn a lot, as I've been doing over my past 10 years. We learn a lot. But also, as at the end of the session, you always summarize the literature, you summarize the evidence base, what we are doing. It's very good that the clinicians get access to this very important information to benefit their patients. There is a concept of penetration. It's a concern that most of the patients don't have access, and even their cardiologists are not aware that you can treat such a multivessel complex patient on a PCI approach. So it's very helpful to both of them.
Excellent.
The way you do, because you're not only doing the case, you are sharing the evidence behind the decision.
Beautiful.
So watch here, Roberto. We've been doing this case now for 48 minutes. We started at 8:04. We have not mentioned any sponsor, any company here. And that I think has always been the truth in the message, that look, learn how to use it, and not this is not to advertise or to mention about the sponsors. And
Diag always the white side.
If you consider
Right.
that
Always
95% of the
Okay, go
innovation
back.
come from the
You?
stakeholders from the
You can see
industry,
fluoro.
it's impossible
No,
to
please
teach
sit down.
without
Poster.
exposing the technology
that?
like we just did here.
12,
And
14.
once you share the technology for the sake of the patients, you are doing a good
You
job.
need that. Okay. Low to 8. No, 8.
Absolutely.
Okay, both 8.
Both are 12 atmosphere. It's a
Okay,
trio
down.
and 2.75.
Let's dilate the LED.
Yeah.
Proximal. Okay, go
Yeah.
up here. High pressure.
We're going 24 atmosphere here,
Okay, down.
and we go a
Okay,
little
let's do the
proximal.
final imaging.
No, proximal more. Yeah. Is that area open?
Down. Yeah, it is open.
Proximal?
Yes.
No, there looks like a little dent. Pull back few millimeter. Yeah, good. I'm going
We are
up
outside. We are outside the stent now.
Okay, no, we don't want to be outside the stand.
Yeah, that was outside the
I
stent.
mean, a question to you from
go.
an audience in India.
Yeah.
It's a straightforward answer, but can we do orbital in balloon uncrossable lesions?
Yes, answer to that is yes.
Down.
You can definitely do. The most there, I would say, probably the laser takes it, but laser is not available everywhere. But yes, orbital can be done as long as you advance your wire.
Okay.
To me, those cases actually do very well with the rotational atherectomy. We have cases where balloon uncrossable. We did try to do orbital atherectomy, and it did not go because what happened is the tip of the orbital does not have a abrasive surface, no diamond. So we actually have every year. Now, of course, we do orbital very little. About the 70 cases per month we do of the atherectomy. Orbital makes only 3-4 cases. Majority are the rotational atherectomy and about 6-7 the laser, which is uncrossable lesion, which you just mentioned. So orbital, in the past, we used to, when doing a 25-30 orbitals, we used to get at least 2 to 3 cases per year where orbital will not go, even in a, it's a tight, long lesion, because of the tip, it just keeps coming back. And then we change it to 1.25 bar after the rota bar, and case is done right away. So that will be the, I would say, the difference which we have seen. Now, then to answer that, we made the micro crown. The micro crown, only thing the engineer made, not a continuous from the tip. They made a small, about 3 millimeter at the tip, abrasive surface, then there is a gap, and that was the same, the rest of your regular crown. So there was a gap. So we did a trial with ourselves in Japan. So we found that 4% of cases,
Can you show the IVS?
it twisted in between. So you have the abrasive surface,
Okay,
no
start
abrasive
rework.
surface, then abrasive surface. The
Distal
catheter
LED,
used to
very
turn,
aggressive vessel.
twist in that area. So they took it out.
Coming.
So orbital team took that out completely.
I
It's
see
no
some
longer
bleach,
available now.
some blanch.
But that was the micro
Nice.
crown.
Nice landing zone.
But that was not a full concept. You had to have all
Yeah,
throughout
very-
abrasive surface. You cannot have interruption in the middle.
I'll come to
Learn
the
very well.
before the
Yeah.
Samir, one
diag.
question regarding the provisional
Nice
approach.
area.
Some people in Brazil are not
Leave it
that
inside.
reluctant to
Again, left
use
main
rota
parent.
after a small
You can take it out.
dissection. Would you do rota after
Nice
dissection?
transition.
Well, I mean, you want to avoid, in that particular case, if you did a balloon and you see a bad dissection, you should avoid rotational atherectomy, or if patient is stable, let it go and come back in a while. But now, if you can get that case pushed with the IVL, that's another way. But yes, you're right. If you see an obvious dissection, our threshold of doing rota is very, very high.
Yeah.
Maybe just to the failure, if you cannot do.
After
So
the
this is
D2,
osteal lesion.
This is after D2, eccentric shape,
Oh,
but
after
area,
D2. Oh,
area
that's
is
the
more
one.
than 5.5. This is after D2.
Okay.
Now coming to the proximal. Here is like more than 10. Well expanded. Nicely.
Proximal edge. Yeah.
proximal
Go
edge.
back there. Right there. Yeah.
Yeah, this is the
It's almost
proximal edge.
good.
On
Yeah.
the plug with normal position,
Yeah.
no dissection. Area is open.
Nicely placed.
Yeah, well expanded.
More
Samin,
important is well positioned.
another question from the audience. You've kind of addressed it towards the beginning. When will we see back burying rota?
Yeah. So very important. I actually have taken 2 trips to their plant in Minnesota, and we actually have the burr with a totally fully that abrasive surface backward and forward. And we did a experiment in the in vitro, and point happened, the 1.25 bar is still got stuck. Others did good. So therefore, now they're going back to the drawing board. I said, that's the biggest culprit. So we are supposed to go maybe in next few months and try to look into it, that what can be done. But yes, I would say probably for the trial point of view, maybe before end of this year, they may do a feasibility study of 50 cases and so, and they're already working with the FDA to submit that. But yes, we'll have it very soon.
Excellent.
Looks great.
So,
Wow. No, good. And left main was not bad on the
No, but yeah,
imaging.
again, we confirmed that, like 10. Yes,
Okay.
black,
Wow.
8 then.
Good. So let's see.
Quickly change a
Yeah.
patient. We can do another case when
Yeah.
he's doing his
No, but you will be
lecture.
talking there. So let's go to our presentation now. This is an excellent demonstration of the, another will be a third stage, not bad in this particular case, 81-year-old. Come back with the calcium, we see the circumflex also very calcified, and that was our plan, which we did. ONDS and mini crisis stenting. We just did not had a time to go our OC criteria, which we always do. In this particular case, will fall into the LMCA disease on the left, although it turns out to be not much LMCA disease on with the imaging, but angiographically was clearly 50-60%, a little bit of bifurcation. So it by criteria originally, when you say it's rarely appropriate, which in the past you used to call inappropriate, but this particular case has a heart team discussion. Even surgeon at age of 80 plus are very reluctant, so I would say it become A after the heart team discussion. With that note, we actually have the two interventional publications, which is about the DCB, which is taking the center stage, two trials, solution ISR and solution de novo, and then Anu will talk about the yellow 3 studies of Evolucom in maximum statin therapy in chronic coronary disease, because her that intracoronary imaging and transcriptomic characteristics before and after maximum lipid lowering therapy, the yellow series of studies which have taught us quite a bit over last 10 years. So simply the two of them I'm going to go through. Solution for ISR. This is the first trial. Remember, agent trial was approved based on, they compare the DCB, the paclitaxial eluting stent, compared against the balloon angioplasty. But what is the class 1 recommendation for DES ISR? Either you do a re-DES or you do a drug-coated balloon. So therefore, they still allowed it, and that led to approval of the device, which is fine. So when we organized this solution ISR, I was in the steering committee, that does not make sense. You have to go against the re-DES. And this is where we say, okay, still we have to answer. So 80%, we have the two arm, that patient either get the re-DES or balloon. So what happened is the balloon angioplasty group was very quickly done. Then of course re-DES take a little time, but all the cases were done, whether one or more than one layer of stent. So this is the solution. And how the whole question, you know, the paclitaxel has been there for 15-20 years because of lipophilic, and it's not a lipophilic agent with the sirolimus, and therefore they had to do a lot of work in terms of the micro reservoirs as shown here, and then have the biodegradable polymer, and then a special proprietary phospholipid coating. So key is that so that drug stays there. So very important is you can put any drug on any stent, any balloon, but how much it goes into the vessel wall, the transfer efficiency is the key. And this is where after the initial work, and we know that now we have the magical the drug-coated balloon has been there for quite a while in India, but here in United States about 4 or 5 years ago, they started with the solution trials in the initially ISR, then a small vessel, and we have been part of them, and we have been the lead enroller in the trials. So just to say that this was the trial of the solution for ISR with the 210 cases in the DEB group or 208 with the control group, and basically regular technique wise was done. In the control group, about 2% of patients, as you said, DEB against control, and control 80%. 80% of the patient have a stent, and the DEB group of 1.8% had a bailout stenting, and that led to these results. The DEB and control identical. DEB slightly went higher numerically, you can see, but no p-value significance. Even lesion thrombosis was no difference, and at 1 year. Individual points is very interesting. What they wanted to say, you know, with subgroup, they also wanted to know that what happened that 80% DES group, DES versus balloon angioplasty. And you can see here, which I made it important, that once you have a balloon angioplasty against the DEB, did great. See, that favors the DEB. But when that 80% group you take of the all trial, the 80% of those patients which were got the DES, the DEB failed. So answer they came with the two negatives, which you can figure that out. That the DB was not non-inferior, not to say the inferior, was not non-inferior to DES. So clearly we know that once the DES, DB not the answer, and this is basically was there. Second, so question is, what is going to happen? DCB will not replace the DES. Instead, their value may be in expanding the therapeutic toolbox for ISR, providing option to treat restenosis while preserving the vessel for the future. Key is what we learn also, that by doing the DCB or DEB, you didn't penalize the patient. Patient still may come back with ISR, but did not have more MI, didn't die. So therefore, it's okay. You want to avoid the metal, give it a second chance for other technique in the future. And this is, as I said, first enrolled cases we did here at Mount Sinai, both for the de novo as well as for the ISR. And we were the lead enroller, as I said, with the 63 patients in this trial. Second was solution de novo, which was done multi-center Europe trial, not to the United States, because we have United States trial still ongoing with the solution de novo study, small vessel. There they took all the patients with de novo coronary lesion, small, large, and so open label, of course, and a large number of patients, close to 4,000, and procedural statistics, and so which I have put it here, nothing different. They allowed to do even rotational atherectomy. Of course, the specialty balloons were used almost in 30-40% of cases, which happens. And the more important, people will ask that, yes, what was the number of using the stent in the in your DEB arm? Same thing. What happened about 2% and so. Now, individual endpoints, as you can see, primary endpoint of the target vessel failure, which is the MI revascularization as a death, was identical, slightly DES favorite, but otherwise no difference. The target vessel revascularization also about 1.2% in favor of the DES. So you can say, based on this, I think both are okay, but DES definitely have a small advantage. And these are the individual endpoints. You can see again the height of the our drug coated balloons compared to the DES is higher in most of the categories. And very important, of these 3,600 or 3,400 patients, then these are the intention to treat, because they use the cases were complex, bifurcation, which are not part of the original trial. So they went to the per protocol. And guess what interesting happened? Per protocol analysis of the 3194 patients showed 1 year target vessel failure rate of 5.2 in sirolimus group, and DES group was 4.1. So risk difference was 1.09. They did not meet the criteria for non-inferiority. That basically means it was inferior in the per protocol cases. So this is whole question. So and that's why when they came to America, and these are the individual things, large and small vessel, slight favor of the DES in the large vessels, and so therefore in the United States at present, same trial is going on, solution de novo. We are, I think, now second or third, because we have so many DCB trials, but it's ongoing. Once it is done, we'll really answer the question in the small vessel. Large vessel will not be shown by the American US trial because they are not the part of the equation. So with that note, this we continue to really say, and they put it very nicely, as you can see, at 1 year, the primary intention to treat analysis, a strategy of PCI, using sirolimus eluting balloon and provisional DES was non-inferior to the systematic use of DES for primary endpoint of target vessel failure. But the per protocol population sensitive analysis did not confirm non-inferiority. That basically, to me, it was inferior. As we know, with clinically driven TVR occurred more frequently in the SEB strategy group at 5 years. What they're saying is, 1 year is 1 year, but we are saying that not putting a stent is a long-term benefit, and this is the secondary endpoint of this trial will be 5-year data. So with that note, I now ask Anu to present her series of yellow trials, and she has put her lot of time, many years into teaching us in the various aspects of the yellow in various publications. So, no, the first one will start with the yellow 3, which latest came out in the imaging, in the JAC imaging.
Yeah, so now we're not here. We're not starting with yellow 3. We got to start from the entire yellow family of studies that we actually did here in Mount Sinai. So the important question why we started was, when patients come to see you, despite good medical therapy, good cholesterol management, they still have new lesion formation. So the question is, doc, what do I do? So one, new lesions could be obstructive, new lesions could be non-obstructive. So we need to answer both of them. And the question is how we prevent progression and induce regression. A very difficult topic, but I think we'll try to answer as much as possible. So the whole yellow 3, yellow 1, yellow 2, yellow 3, you see here from 2010 to 2024, actually the yellow 3 just got published this year. So the first in 2012, and over the years, medications have changed, therapy has changed, guidelines have changed, imaging has changed, a lot of things have changed. So we were trying to incorporate and understand exactly what happens in the coronary arteries. The first question was that, do statin really work? And if statin works, do you need the intense therapy? Because at those days, guidelines therapy was not to what we are right now. So we randomized standard of care, all kinds of statin to rosuvastatin, which was at that time initially introduced. The only thing was we checked the lesions of 6 to 8 weeks. What we did was we took patients with obstructive disease and wanted to see by giving statin, will it change? So obstructive was that patient had to have FFR of less than 0.8. So that was yellow 1, 2, and 3. So let's go individually. So to understand that, we had to image. We did both intravascular ultrasound, and we used what is called as NIRS, which tells us what lipid is. So total of 87 patients, standard of care, aggressive therapy, patients had to have FFR less than 0.8. So once that was done, when they came back, we repeated all the imaging. So interesting, of course, with high dose statin, you see a cholesterol, LDL, everything changes. And since it was only 6 to 8 weeks, we saw some change in plaque burden, but increase in FFR, essentially trying to say that the plaque regress with FFR improvement, which means you don't need to stent the patient. That we saw some trend, but we never saw p-value because one, the numbers could be low, and that the number of weeks we treated probably less. But not now. In the future, we are going to show you some sub-studies of yellow 3 where we are showing that definitely there is a change in the vessel wall physiology when the lipid changes. So this is what we showed, that LCBI definitely decreased with aggressive therapy. This was a case example where you see FFR 0.74 became 0.78, so a change in LCBI. But what we saw was the change in the LCBI, which is on the right hand side. You see that third tertial is that majority of the larger the LCBI, the bigger the change we saw in the patient. So and the group, I would say 30% of the patients, since they were all comers, we did not see any lipids in this patient. So if you take the patient at end stage atherosclerosis, most of it you will see calcium, maybe you'll not see a lot of lipids. So you need some lipid, or essentially we're trying to say get the patient early on in the disease process. So what did we learn from yellow 1? That aggressive statin works, and greater the LCBI, that's when you see big change. So now what happened is, if we want to go to yellow 2, one, you have to make sure there's lipid before you enroll the patients and say that, okay, there is some change in the atherosclerotic plaque. And we wanted to understand how exactly the changes. And by that time, optical coherence tomography was introduced. We could see what's called as the fibrous cap. These changes happen. Exactly how does these changes happen? What we know is the HDL functionality. So this is where I think when patients are coming to see you in the office, we tell them, okay, yes, your LDL change, LDL change. Nobody is talking about HDL. HDL also is very important, and HDL has a certain function which is called as a cholesterol efflux. So let us go a little bit to the basics of what we learned in biochemistry and our early part of our medical school. So you see that the entire cholesterol mechanism happens between the intestine, where triglycerides come in as chylomicron, go to extrahepatic tissue, inside the liver. In the liver, there is extra formation of cholesterol. I will go through some of the steps of the cholesterol mechanism, and the whole process goes on. So body nature has created a homeostatic mechanism. So this homeostasis has to be maintained. So if you see the HDL, which is extrahepatic tissue, the important part of what HDL does is reverse cholesterol transfer. It takes from the hepatic tissue, extrahepatic tissue back into the liver, and that's where it gets. So this is, I think, something we need to learn also, is that LDL. You see that majority of the LDL, which is LDL, ILDL, VLDL, or that we showed in that hepatic mechanism, which has ApoB, okay, these are atherogenic, red, okay, but when it is HDL, which is ApoA, it is atheroprotective. So very important. I think we will hear this, and patients will ask you this question: what is ApoB, what is ApoA? So ApoA, so like I always say, if you are A plus, you're good in life. When you become B plus, you're bad. So just remember that way. A is good, B is bad. And then little a is also bad. So that will be another lecture by itself. But just for you to know that these are something that we need to understand. So very clear. You are on the left side, which is your flow inflammation, atherogenic, which is anti everything, and the red. If your balance is good, you have a healthy vessel. Healthy vessel is a vessel that moves and no plaque. When there is, for whatever reason, the imbalance happens, the homeostasis mechanism of what I showed you between intestine, extrahepatic, hepatic tissue changes, you start forming the plaque. And why I'm going through this is, when you talk about this thing, that's important how this lipid moves from everywhere. You have to understand macrophages, and I will tell you why, because this is also we found in yellow. So macrophage M1 is pro-inflammatory, not good, okay. M2 is anti-inflammatory, phagocytosis, removes the cholesterol. So you need M2 macrophage, you understand. So just remember that M2 macrophage is good in life. And the most important thing which we found is that mitochondria is the powerhouse. Mitochondria is required for everything in our body, and that is what you will see, mitochondria in the entire of the process. So this is going back to how exactly the plaque is formed. I showed you what a normal vessel should look like, what an abnormal vessel will become. So how does it happen? When you have a lot of LDL, which you see there, gets into the vessel wall, this macrophage, which is M1, M2, goes there, takes it out, and it forms, foam cell. When a lot of happens, apoptotic cell happens. So, but that's also called as efferocytosis. If your macrophage is a good macrophage, it will take away all the cholesterol. So if you see that the macrophage there, from there the HDL takes along with ApoA1 and goes back to the extrahepatic tissue. So you need what is called as apoptosis should happen, efferocytosis should happen. So this is what is called as how HDL works. It is reverse cholesterol transfer, takes the cholesterol from the tissue, plaque into the liver. So very important. That is how plaque changes. So on the macrophage, there are what is called as a certain receptor, ABCA1, ABCA2. So these should be functioning so that your cholesterol is taken out. HDL should work through that. So very important this happens. So going back to where statin works as a HMG-CoA reductase, which is the rate limiting step in cholesterol formation of the liver. So another important question the patient asks, should I take a statin or should I do lifestyle modification, not eating cholesterol? So that is where you need to do a testing to understand what is problem with that patient. But if it is something that's genetically forming a lot of cholesterol, statin does work. And very important is more other steps are important, because in cholesterol synthesis, which starts what is called as through a mevalonate pathway, there are two enzymes, which is SQLE as well as a DHR. You'll see that, and these are the enzymes, and we will show that they are very important upregulation in yellow 2. So having known how this thing happens, we went embarking into yellow 2. One, you have to image. Two, you have to understand how the cholesterol is removed. So you have to understand that the HDL functionality is working. HDL is doing its job, which is cholesterol efflux. Does that happen? Why does it happen in few patients? Why does it happen in few other patients? That is why we had to understand the genetic profiling. So you got to understand how the gene is. So everybody comes with the DNA. DNA is then translated, becomes mRNA. mRNA then becomes a protein. And that is how you will check that in the blood. We check the mRNA. So going back to our yellow 2, we checked cholesterol efflux. So we did all the assays in these patients. So the patients came, they had lesions. We did OCT. We checked their NEARS, and we was given rosuvastatin. So when they came back, what did we find? Of course, LDL change. Remember I said B is bad, A is good. So B went down, A went up. So I think statin was doing a good thing, and CRP of course will decrease when you use the statin. And cholesterol efflux capacity, which is CEC, if you see that, definitely improved in this patient. Essentially, all the mechanism that we thought how the cholesterol removes from the plaque was working in this patient when they got the statin. So this is cap, by doing so, cap thickness increased in this patient. So if you go to what exactly changed or why the cap increased in these patients, two things were important. Patients who had a good cholesterol efflux capacity, their cap improved, and that in fact reflected by decrease in inflammation or change in the HCRP. Now, I showed you the enzymes that were responsible for cholesterol mechanism, which is SQLE, DHCR24. So these were the enzymes change, which means the statin was working through that pathway. Another important is those ABCA1, ABCA2, the receptors on the macrophage, which I showed, which works in cholesterol efflux, that also there were changes in this patient. So essentially telling that the mechanism, what we knew works in this patient. This was the central figure, and this was again the intravascular imaging of the similar paper that we had shown. At those days, we used machine learning model to see who would respond and who would not respond to statin, because we still know there are few non-responders. So what we found was there were certain important patients, they had certain genetic predisposing markers who did not respond to statin. We do have their genetic profiling, which we will use for the future to use them. So LO2, what we studied, that there are statin non-responders, so you need aggressive lipid lowerings. By then, new drug PCSK9 came into existence, maybe longer duration, because this also was 8 to 12 weeks. And then, of course, enrollment was based on OCT thinning. So we are just showing how each medication works. By then, we had PCSK9, which was evolocumab, alirocumab, and of course, inclisiran also came into existence. We use evolocumab. So this was yellow 3, longer duration. We used OCT, lipid arc as the enrollment criteria. All patients had to be statin. By now, we know everybody has to be on statin. And then you do aggressive therapy by giving evolocumab 140 milligram every 2 weeks for 26 weeks. So we did again genetic profiling. Here we did a transcriptome. It's a different technique by using bulk RNA. Bulk RNA means you take all the cells and you analyze them rather than doing single cell. Single cell is very important so that you will understand the various cells that we described, which cell works, but that would be the next step. So you see that fibrous cap improved and LCBI decreased. So what did we show? If you see that in these patients, example, fibrous cap was 60, improved to 90, LCBI was 782, became 285, and some change in the IVUS. So what we found was, even in this patient who had statin, who got evolocumab, about 80% fibrous cap improved. We call the fibrous cap responders, and some of them LCBI decreased, which we called as LCBI responders. So there's a term, we call this now a melting butter sign. The butter that is in the artery is melting. So this term has been coined, and 20% we saw was non-responders. So very important, everybody has to learn. Look at the LDL on this patient, 78 at baseline, came back LDL of 7. Fibrous cap 50, 50, LCBI same. So what we are trying to say is, we are seeing the patients in the office, we are looking at their LDL and you're saying, hey, you're doing a great job. Patient comes back with new lesion, comes back with MI, okay? So there is this 20% patient and we don't know why this is happening in these patients. That is what we found out. So this is the central figure that just got published this year in 2026, the melting butter sign, which we have shown there. So the question is, was a response, both responders, non-responders, similar to total cholesterol and LDL? Yes, similar. So what did we find? So we know that there are 20% who are not responding. Is there something in their gene that is telling us why they are not responding? So this is the bulk genetic analysis that we had seen. So you take all the genes, then you put them through what a special pathway, they have created what is called as engineering pathway. And in the pathway, it will tell you these genes are responsible for this particular pathway of the body. So what did we find? There was upregulation of what is called as ATP synthesis, oxidative phosphorylation, and more important is mitochondrial translation, which is responsible for protein synthesis, cell response to stress. So mitochondria is the key, which I showed you how important mitochondria is. So there was a down regulation of mitochondrial dysfunction, down regulation of cell surface interaction with vascular wall, which is important how the cells get stick to the vessel wall when there's a lot of cholesterol. So down regulation of the bad pathways, up regulation of the good pathways. That's what we found. So going back to, can we differentiate responders, non-responders? So that's where we are. Responders had good mitochondrial function, good cellular response to stress, and that was responsible for protein synthesis. Non-responders, everything means mitochondrial function did not change. So mitochondria is important, and this is what we had found in the theme. Now, when the patient is coming to see you in the office, can we understand, is there something what is called as a baseline gene that will predict who responds and non-responds? Yes. So fibrous cap thickness change based on the baseline gene. We had found some baseline genes, same thing for LCBI change. There are some baseline genes saying that if you have this baseline good genes, you are a responder. So what did we find? Yellow 3, that comprehensive assessment of mitochondrial function is a key. Everything else I have mentioned. So mitochondrial function, mitochondrial function, mitochondrial function. And the other thing we want to do is single cell RNA rather than the bulk RNA to understand exactly which cell line is responsible to change. So this actually, as soon as I presented in AHA, I had shown this, whatever I just spoke, is the same thing that is available, that we made a nice animation with help of Andrew and Yulia. You see how the monocyte goes in, changes into macrophage, macrophage inflammation goes up, starts eating all the lipids, and inside the macrophage is the mitochondria. So when mitochondria gets overworked, this is what is called as a reactive oxygen species, which is not good. You cannot have reactive oxygen species equal to red. You do not want that. Okay. So, cell death, more lipid comes in, plaque is formed. So you see that cap becomes thin, 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 and there's a risk of rupture. When you give evolocumab, everything reverses and things get better. So you see that? That is what the cell is not adhering anymore to the cell wall. That's what we had shown. And mitochondria start functioning, if you see that, everything gets better. So what actually we showed was that what we saw in the genetic changes, we saw genetic changes in the phenotypic changes. And this is the first time somebody actually that we showed that genetic changes is equal to phenotypic changes that we have seen. So going back, mitochondria is the center. Mitochondria are responsible for efflux. Mitochondria are responsible for anti-inflammatory as well as mitochondria are responsible for efferocytosis and other parts of macrophage functioning. Bad mitochondria, you get atherosclerosis. So the two things we are promoting, melting butter and healthy mitochondria. You need a healthy mitochondria for survival as well as living. So how can we get healthy mitochondria? No definite disease, medication has been created, but is there something we can do? Definitely. Dietary intervention. If you see here, good diet, which is often Mediterranean diet, calorie restriction gives you healthy mitochondria, nice ATP formation. The American Western diet, which you see there, is bad, dysfunctional mitochondria. So you can change your diet and get healthy mitochondria. So that is what I promote: red juice, beet juice, green juice. Okay, yes, that promotes healthy mitochondria. That will be another lecture of what is good food and how to remain energetic your entire life. And this has been proven and shown that exercise improves mitochondria. Very important. So this is something everybody can do, that you can exercise. That is why this trial showed that overall this data support notion that long-term engagement in multiple type of physical activity help extend lifespan. So, exercise and physical activity is part of the guidelines, which is very important. They actually increased it. The ESC increased. It used to be 150. They made 150 to 300 of physical activity of moderate, and high intensity is 75 to 150. That is where we are. So this is a yellow 3 done, and we learned that just by doing mitochondria is not enough. I think we need to go to next level, which is proteomics, metabolomics, and that way we'll get a biomarker. So when the patient comes to see you in the office, you can do a biomarker and say responder, non-responder, and start the treatment. Meanwhile, lifestyle modification is very important. So yellow 4, we are going to start, where we are going to use transcriptomic, metabolomics, and special testing to understand the patient's mitochondria. So there are special tests for that. So this is just the take-home messages, which we have gone through all of them. So yellow 3 is there is non-responders. We need mitochondrial recovery, inflammation resolution, and this gives rise to what is called as personalized prediction. So future is, in the past, you take 15, 20, 30 years to find a drug. Hopefully, with the current AI-driven drug development, we should be able to get a drug towards mitochondria. So when the patient comes to see you in the office, do the blood test, biomarker, use the AI model to understand exactly what kind of medication and what kind of, exercise regime this patient can, leading to what is called as a personalized treatment for CAD. This is the future, and this is what we are going to coin. And all that I've discussed right now is available on yellowtrials.com. And these are the various publications and more. This year itself, we have had about 6 publications from Yellow and the sub-study of the Yellow 3. So that's where we are with that.
Anu, remarkable presentations. I think one of the best ever in the 17 years we've been doing CCC live cases. It is the past, present, future, your life's academic work for the last almost 2 decades. Congratulations, and such a relevant presentation to everything beyond all the catheter manipulation. This is the foundation where we need to focus.
You want to talk? So the final, if you see here, this was a beautiful editorial written by Farooq Jafar. So if you see here, in conclusion, Kinney et al. Are to be congratulated for leveraging clinical imaging and transcriptomics to the further understanding PCSK9 inhibitor responsiveness in clinical population. Based on this integrated framework, we may be witnessing the dawn of personalized medicine for CAD pharmacotherapeutics.
It's unbelievable.
I think that is exactly what I had said it without the editorial.
That is
Just
it, without
fantastic work.
Yeah. So let me just complete it now.
Yeah,
Yeah,
go
beautiful.
ahead, please.
Just quickly finish it. So we always go through our sirolimus DEB similar to usual care in DES ISR with predominantly re-DES. I put only one, but also negative, because we learned that only if you go against that re-DES, it failed. Second, the sirolimus eluting balloon PCI similar to systemic DS used in de novo lesions for target vessel failure. This was one trial, and of course we have talked about the single center trial of the CCD intravascular imaging with the PCSK9 inhibitor therapy showed a lot of things for us. So besides just decreasing the LDL, decrease inflammation, mitochondrial function, oxidative stress, all those. So now we can kind of predict the region why patients are not responding and so. So quickly, our three questions. Following are the true statement regarding the results of the solution for ISR trial comparing sirolimus eluting balloon versus standard of care for DS ISR except similar TVF, similar lesion thrombosis, similar ACB superior to balloon angioplasty assignment arm, ACB similar to re-DS assignment arm, and similar MI rates in the both groups. Clearly it was not in the re-DS assignment, it lost to re-DS sirolimus eluting stent in our solution 4 trial. Then the randomized comparison of the solution, the sirolimus eluting balloon versus systematic DS all-comer de novo lesion showed similar target vessel failure between two. Sirolimus eluting balloon was not non-inferior to DS in protocol per protocol analysis patient. Similar cardiac death rates with SCB versus DES group, lower MI rates in the sirolimus eluting balloon versus DS group, and similar lesion thrombosis between two groups. So it could not show. We could not show that it was not non-inferior. It looks like it was inferior, but with the word they used, could not show that it was not non-inferior. And then finally, that's why we did a small vessel trial ongoing in the United States. Following are the true statement regarding the intracoronary imaging of the Yellow 3 trial of maximum lipid lowering therapy, except follow-up duration of the trial was 26 weeks. OCT showed fibrous cap thickness of less than 65 micron in majority. Almost 50% patients showed no reduction in the lipid core burden index. Minimal fibrous cap thickness rose more than 27 micron from baseline to follow-up, and analysis showed restored mitochondrial function in majority. Clearly, it was not the 50%, it was whatever we take it, the 20%, around 20% was non-responder, not 50%. With that note, with the extensive teaching of the yellow concept and very complex case done beautifully with the change strategy, but show the orbital atherectomy to be done safely was the hallmark of today's presentation.
Samin, always much to learn from you. Stay there on that picture. This is the art of wearing the tie with the lead. So all preserved there. Anu, beautiful case, great presentation. I think it is appropriate for me to read exactly a note which I have just received. This is coming to us from Dr. Fausto Ferres, who's a dear friend, possibly the best educator in the entire Latin America. He's the chief of cardiology at Dante Pasanesis. He has been watching the entire broadcast. He says the live broadcast was spectacular, excellent teaching, and a brilliantly demonstrated technique. Congratulations to you all. I think that sums it up beautifully. I'd like to thank Dr. Roberto Botello for joining me. Anu, great presentation, great case. We stop here and we'll join you on August the 18th.
No, little change.
August 24th, 5th.
Okay, 25th.
Hold on.
25th.
I'm glad we are stating that.
25. August 25.
August 25th.
Excellent. That would be the next case. We'll send that announcement, put it on the website. Roberto, thank you for joining us. Anu, great case, excellent presentation.
Okay,
Thank you,
beautiful.
Samir.
Thank you. All right, my friend.